Prof, is screening for prevention of cardiovascular risk and lifestyle modification something that you do routinely in your practice?
Yes, indeed. I think we are beginning to offer that service routinely to our patients, uh, taking their height, taking their weight, taking the blood pressure, reporting the BMI, and also doing uh, fasting blood sugar. These are services that are now routinely provided. But to look at the import and impact of those services is something that we have not looked at. And I'll be looking forward to see for those people who are doing this, what advantage has it brought on the welfare and well-being of patients that are on treatment of HIV infection. I'm looking forward to what you have to say on this.
Okay. So thank you very much. Dr. Hanley and colleagues looked at the effects of lifestyle modification and annual screening in the prevention of cardiovascular risk factors in South African women with HIV, and they presented their data in the just concluded IAS. We know that HIV, hypertension, and obesity affect women in low and medium countries in different ways, as we have data. So the study actually evaluated the integrated lifestyle interventions using the WHO package of essential non-communicable disease, what we call WHO PEN, okay, for modifying risk factors for cardiovascular disease in South African women. So the WHO PEN, as we know it, is a conceptual framework that for primary healthcare in low-resource countries. Essentially what it does is it has defined some minimum sets of essential interventions to be implemented for early detection, modification of risk factors, and then medication for prevention and treatment of non-communicable diseases. And just like you said, alluded to earlier, they look at blood pressures, they look at BMI and other risk factors. And so it's a package which WHO has introduced. Okay. So this study is what we'll look at is called the ischemia study, integration of cardiovascular disease screening and prevention in the HIV management plan for women of reproductive age. So it evaluated integrated lifestyle, as I said, interventions that using the WHO package of essential non-communicable diseases for modifying the risk factors for cardiovascular disease in South African women. So it's a prospective two-arm quasi-experimental study, and women that were recruited were between the ages of 18 to 50 years, and they must have been in care for longer than 1 year. So essentially, they compared those that were research clinic-based women and then compared them to routine care at the PHC. And the center that was chosen is Peri-urban Township, somewhere in KwaZulu-Natal, South Africa. It's called Umlazi. And we know that this is the second highest, this place has the second highest prevalence of HIV globally. And this study started in November of 2018, and they recruited and followed up patients up to February 2022. And they had visits at yearly intervals. They were followed after every 12 months. So essentially, the results, a total of 372 women were enrolled. But at the end of the study, they had in the intervention arm 149, and then 120 in the control arm. You will notice that not all the women that were enrolled completed, but this is what they had. And Because if you add 149 plus 120,
You won't get
you won't get
372.
372, so that you are not wondering the difference. So these are the people that completed at the end of the study. The mean age was 36 years. But the participants in the intervention arm, they were less likely to have elevated fasting blood glucose. They reported low level of exercise though, and they were more likely to report a healthy diet, those on the intervention arm. And they had a significant absolute difference in reported exercise, blood glucose, and waist circumference. Their HDL, which is the good cholesterol levels, improved significantly from abnormal to normal levels. And then both mean waist circumference and BMI increased significantly, which is not so good. So, but there was no significant effect of DTG in these patients on their BMI, blood pressure, or metabolic syndrome. So this is what we got from this ischemia study and the report of the screening. So some of the take-home points: lifestyle intervention and regular screening for cardiovascular risk in stable treated women with HIV from low-resource countries is beneficial. There are some benefits to it, as we saw. And then lifestyle interventions did not change the cause of obesity. So despite the lifestyle intervention, these women also still gained weight, as we saw from the increased BMI and waist circumference. Dietary practices and level of physical inactivity still remain suboptimal despite the intervention, which is also something that came out. And then high rates of poverty, limited access to healthy food, and lack of safe spaces for physical activity were identifiable barriers. And this is a challenge that we all face, particularly in this part of the world, where to exercise now has become a challenge. Okay? We also know that lifestyle modification, regular screening are critical even in the presence of HIV-related chronic inflammation, as we said earlier. So, part of their recommendation too is robust monitoring for cardiovascular risk in the era of DTG. So if patients are on DTG, they are recommending that cardiovascular risk is monitored. Is there anything takeaway that would be useful to us in Nigeria from this study?
The screening that you talk about, we are already actually implementing it.
Yeah.
I think the additional point that this study talk about is the lifestyle intervention.
True.
And that includes pieces of advice that is given to our patients when they come to the clinic, in particular dietary advice, the need to take medication on time, the need to do exercise, and of course the availability in what they did, is that professionals that are actually not medical doctors, dietitians were made available to also give piece of advice. So this lifestyle intervention, I think is very key.
Yes.
And I think is something that we should encourage, the HIV clinicians or most facilities that provide HIV services, treatment services, to take on in addition to routine, antiretroviral services that we are giving. This lifestyle thing, I think, is very key, and we should let Nigerians know that out there we have data to show that providing those services in addition to routine measures, that you are screening them for other diseases that are NCD, so that those NCDs don't come. I think some additional thing that we should give is this lifestyle, intervention pieces of advice. And I think we should thank the people who have the data and share the data with us.
Thank you very much, Prof. I think that's a very important thing that we need to take into our guidelines as we consider revision of and updating of the guidelines. Thank you very much, Prof. Thank you.
You're welcome.